Breast cancer. It's a diagnosis that stops us in our tracks. It carries so much weight, fear, and uncertainty. It's a natural reaction, especially when we hear stats like 1 in 8 women will be diagnosed in their lifetime in Canada. But instead of focusing on the fear, what if we focused on the factors we can influence? What if we shifted the conversation from just awareness to actual risk reduction? I'm naturopathic Dr. Ann Hussain, and this is Face to Face, the Hormone Health Show. Breast cancer is obviously a huge topic, and we can talk about all the different aspects of it. But today we are specifically zooming in on prevention and risk reduction. According to the Canadian Cancer Society, as of 2025, it's estimated that about 1 in 8 women in Canada will develop breast cancer during their lifetime, and 1 in 35 will die from it. In this episode, we're going to talk about the things that you can't control because it's important to understand and recognize them. But that's not the things we want to focus on. We're going to focus on all the things that we can do to reduce your risk. We're going to talk about some of the confusing information out there in the world on breast density, mammograms, alcohol, genetics, hormone therapy, and lifestyle. To guide us through this, I have a guest who sits perfectly at the intersection of science and compassion. Today we have Dr. Ashley Chauvin, who is a naturopathic doctor and a Menopause Society Certified Practitioner out of Burlington, Ontario. She specializes in helping people navigate life after cancer and through menopause, helping them feel like themselves again. She's a speaker, an educator, and a fierce advocate for her patients. I've come to know her giant heart and smart brains over the past year especially, and I am definitely a better person and clinician for it. Hey, Ashley, thanks for being here.
Hi, Anne. Thank you for having me. I'm excited to talk about this with you.
Actually, before we dive into the science, I would love to talk a little bit about your journey because this work is and can be quite heavy, but it also carries incredible hope. And you work with women during some of these most vulnerable chapters of their lives while they're making very difficult medical and life decisions. And there's a lot that comes up with that, including a lot of information and opinion coming their way. How did you end up focusing your practice on cancer and cancer survivorship?
So from a young age, I've always known that I've wanted to work with people who are affected by cancer. It could be that I've always had an interest in the medical field, but I've always really wanted to be people focused. So I was like, do I, become a lawyer or public relations? So I get to talk to people all the time, but then I still wanted to keep all of my sciences because I absolutely loved like the research and anatomy and how the human body works and all those intricacies. My aunt took me to a Take Your Kids to Work day when I was very young, and she worked at the local cancer clinic and brought me around to chemo, brought me around to the nursing station. And for some reason, I really loved the radiation therapy department. Maybe they were just really fun, or maybe it was all the tech that really intrigued me. But I decided to become a radiation therapist. So I went to school for radiation therapy. And while I was in my radiation therapy rotation, I met the most wonderful oncologist ever. She took me under her wing and allowed me to do consults with her. And I found that although I did have patient interaction as a radiation therapist, the consults were where I got to sit down, ask patients questions, but I was seeing patients more in their survivorship phase. So like their 3-month follow-up, their 6-month follow-up. Patients had so many questions, and these were intelligent questions. These were like, what can I do to prevent things? I'm still feeling tired. I no longer have cancer, but I don't feel perfect again. Like, what's going on? And there was a lot of questions about diet, lifestyle. There was also questions about supplements, whether they be things that patients had read or whether these were things that they had heard from well-meaning family members. I had those questions too. When I brought them to the oncologist said, Ashley, I think that you're great at radiation therapy, but I think you're going to get very bored. I think you need to do more of this. So I decided to become a naturopathic doctor. And I went to naturopathic school always with the intention of coming out supporting people who have been affected by cancer.
I do think you're such a perfect person to guide patients through it. And I love that that person picked up on it, that you're going to get bored here. And you also teach clinicians and other healthcare practitioners with such well-roundedness, right? Like thinking about all the different things to consider as we're creating a treatment plan, including the patient's values, including where they're at, including the evidence. And I really appreciate that about you. And that's where I want to start. Because when we think about risk reduction and risk in general, I actually want to start with that word because as clinicians, and even if we take a look at researchers, we know that headlines and social media, things get blown out of proportion, and we hear things like X causes cancer. But we also know that plenty of people do X and they never get sick, while other people have the complete opposite thing happen, right? So if we take a look at smoking and cancer, everyone who smokes does not get lung cancer, even though there is a causal relationship there. And also, people who don't smoke can get lung cancer. And ultimately, risk has to do with probability, not determinism. And it's really important for us to understand that risk factors aren't a guarantee of disease, right? Like people, even who have strong genetics, don't always end up with disease. Can you highlight that concept a little bit using some risk factors for breast cancer?
Absolutely. So I think this is so important. And even as clinicians, we can sometimes get wrapped up in this, and we can get wrapped up in this in the opposite way too. So we know, for example, reducing risk can be something like reducing BMI, reducing alcohol, exercising, eating adequate amounts of fruits and vegetables. But we also know, at least in my experience, most of the patients that come to see me don't have a history of a high alcohol intake, do have a normal BMI, do have a quite like healthy diet. And they'll say like, why did this happen? And it's important to remember that cancer is not a punishment. So even if you are doing all of the quote unquote right things, you still can get cancer. And even if you are doing some of these behaviors that are not so health promoting, it doesn't mean you're going to get cancer. It's almost like a gamble either way. You're just stacking the deck in your favor. There's also different factors that we cannot control. So for example, when we're looking at breast cancer, the first factor is being born with ovaries. So if you are born as a female, you have a much higher risk of getting breast cancer than if you are born as a male. Age also plays a role. So although younger individuals have been diagnosed with cancer in the more recent years, we are also seeing that most of the time, cancer is diagnosed in individuals, breast cancer, in their 50s and their 60s. Screening has changed based on that. We're knowing that it's happening in younger individuals. But again, age is one of those things that you can't control. As you get older, you're going to have a higher risk. We also can look at the age of first menstruation, the age of your last menstrual period, how many children you have had. So all of these things are somewhat out of an individual's control, but actually play a huge role in risk. Family history plays a role in risk as well. We do not choose our genetics, and they're brought upon us. So those are just some risk factors to consider.
Mm-hmm. And I like the analogy you gave of stacking the deck, stacking the cards in your favor as much as possible. And even that comes with its own limitations, depending on your geography, your demographics, what is happening in your life, your circumstances, and all of those things. And part of that previous risk factor could be exposure to things that you had no control over. And to that, can you share with us a little bit about some of the other risk factors that we can have a bit of control over? And I use the word control very loosely.
So these are things like physical activity. These are things like our consumption of alcohol and tobacco, consumption of fruits and vegetables, consumption of ultra processed and sugary foods, high calories, low nutrient value, versus just the fact that sugar alone is the problem. When it comes to cancer, it is not just like a one shot, one opportunity. Like that's not cancer biology. Cancer biology is so complex. So it's all of these factors put together. When we're looking at other things such as environmental exposures, some of these are in our control, some of these are not in our control, and they're not as high factors. So we can say, for example, that in some cases, exposure to hormones may increase risk, but there's also quite a large body of evidence that shows, yes, maybe it does increase risk, but by how much is really the concern. So another thing that we have to consider that when we're talking about risk is just because a certain factor elevates risk in one way, it's not equivalent to another risk factor elevating risk. So for example, if we're looking at exposure to hormones, it doesn't elevate risk as much as alcohol, or it doesn't elevate risk as much as being sedentary. So it's not only important to look at just the risk factors that may be in our control, it's also important to look at the magnitude of risk that these things carry.
There's nuance there. There's different degrees to which certain factors will contribute, and some of that will depend on dosage as well as a cumulative effect over time, right? And these are the things that often get lost in translation when we have short form content on social media.
It also gets lost in translation when we have a topic that's really emotional, or when we're in a very vulnerable situation and we get this diagnosis. People are willing to do everything. So they're not thinking of all of the nuances. They're just like, it's an all or nothing approach. And I do have quite a bit of people who are coming into my office with a diagnosis of cancer, looking for that cause and blaming themselves, or saying, what did I do? And thinking that if they can take away that one particular cause, that their cancer is going to go away. So the other thing about these risk factors is that it doesn't necessarily mean that if we all of a sudden change our nutrition or start exercising or stop drinking alcohol, those are all good things and we should consider doing them. But if we do them when we have an active cancer, there's no evidence to show that the cancer just goes like poof and it goes away. So that's the other thing to consider.
Can we actually talk a little bit more about alcohol? In recent years, especially, we've had some Canadian guidelines about what the safe limit of alcohol consumption is, not just for cancer, but also other chronic illnesses like cardiovascular disease, cognitive decline, and other things. So, because alcohol is entwined into how we socialize in society, how do you talk to patients about this? Is there a safe amount?
So alcohol is a class 1 carcinogen. And I think, end of sentence, right? So I think the first thing to know is just to recognize that it is a class 1 carcinogen, and therefore there is no health benefits of alcohol. If you are going to use alcohol because you enjoy it, it's part of socializing, that's your choice. It doesn't change the fact that it's a class 1 carcinogen. And I think that's really where the messaging has changed recently, more around harm reduction and actually just being very straight up to the public, as opposed to being like, well, maybe it helps you relax and there's this benefit and that benefit. It's just, there's no benefits to alcohol from a health perspective. What we're recognizing is that after 3 drinks a week, it seems like that is closer to the tipping point of that magnitude of effect, making a difference in cancer. We also have to consider with alcohol, looking at the dose, depending on the amount of alcohol you're having or the type of alcohol you're having. Often the conversation that I'm having with patients in my office is less about not drinking alcohol at all. Patients who no longer want to drink alcohol just come in and say, I don't want to drink alcohol. If people still want to drink alcohol, the conversation is around how much we're having. And when I say how much patients are actually having. So one serving of alcohol is not necessarily what we might pour in our glass. Wine is the biggest culprit with this, because most often the way that we pour wine is at least 2 servings. So for example, wine is a 5-ounce serving. So I say, like, it should be your restaurant serving, not the serving that your nona's pouring for you. Or like in my case, my grandfather's, like, his glass of wine was right up to the top. So I was definitely getting at least 2.5 servings if he was pouring wine. And I think that's partially important to know, because people might be thinking, oh, I'm only having 1 glass of wine with dinner, so I'm only having maybe 5 servings a week, but really they're having 10 servings a week. So starting to talk about that rather than just straight up elimination. When we're looking at alcohol consumption, so even moderate alcohol consumption, which is 1 to 2 drinks a day, can increase the risk of breast cancer by at least 30%.
And because we normalize alcohol so frequently, I think sometimes we miss the forest for the trees when it comes to other risk factors. I want to actually move to a different risk factor entirely, which is breast density. We have more and more awareness about breast density. People are getting their categories. Dense Breast Canada has done a really beautiful job of disseminating information and making the public more aware. Can you take us through what exactly dense breast tissue is and why it's a risk factor?
I love this question. So dense breasts are also another risk factor that you, for the most part, do not control. You are either born with dense breasts or you're not born with dense breasts. Dense breasts are different than cystic breasts. And the reason why I bring that up is often in my practice, I'll ask people if they know their breast density, and they'll say, oh, I have really dense breasts because they're really cystic. I'm like, oh, well, what's your category? And they're like, oh, I have no idea. Or some people will say, I've never had a mammogram. So the only way to know your breast density is to get a mammogram, and that measures your density. And what that essentially means is that when we're looking at a mammogram, we see fat tissue, which is what our breasts are made up of, and then the fibroglandular tissue, which is also breast tissue. And in cases where there's more of that fibroglandular tissue than fatty tissue, we're seeing denser breasts. And that fibroglandular tissue shows up as white, I would say almost snowy. So the more dense your mammogram is, the more troublesome it is for the radiologist to actually see potential minor calcifications on your mammogram. So things can be missed. Another thing about breast density to know is that size of breast does not actually equal density. So again, let's not make any assumptions. The only way to know your breast density is to get a mammogram and to get them checked out. If you are found to have dense breasts, I don't want you to fear and say, oh my gosh, this means cancer is going to be missed. We have seen that, and again, Dense Breast Canada has been such a great advocate for this. If you have a category C or D density, most likely you should be recommended to get an ultrasound or even further imaging. Definitely if you're category D, but I would even recommend category C based on other jurisdictions' suggestions as well. And an ultrasound can pick up those differences and perhaps pick up any cysts or any lesions that may be missed because of the density on the mammogram.
And just to clarify for anyone listening, breast density goes A, B, C, D, A being the least dense, D being the most dense. How about hormone therapy and breast cancer? People come in very confused into my practice, I know, and I'm sure they come confused even more so in your practice because you deal with cancer survivors. What is the relationship, if any, between hormone therapy, like I'm thinking specifically menopause hormone therapy, and risk of breast cancer?
So there's a couple of things to tease out. As I mentioned earlier, it's not exactly, a relationship where if you take hormone therapy, you're going to get cancer, or breast cancer is not caused by hormone therapy. So that is a myth. However, I will say, depending on your social media algorithm, the pendulum swings one way or the other. It's either if there's a history of cancer in your family, you should never take hormones because if you take hormones, you're going to get cancer. And that is not true. The pendulum has also swung the other way. That's like, that study was such BS and they made it all up, and hormones don't impact cancer at all, so I don't have to think about cancer. And if you are somebody who is born with ovaries, you still need to think about breast cancer because, again, 1 in 8 people will be diagnosed with breast cancer regardless if they take hormone therapy or not. What we see the relationship between hormone therapy, menopausal hormone therapy, and breast cancer can be twofold. We know that if somebody is diagnosed with an estrogen positive cancer and they do not know that they have an estrogen positive cancer and they are given exogenous estrogens, that can make the cancer grow. So that can be a concern. That's going to be, most patients aren't going to be in that category because truthfully, that's a rare case. What we see is that for patients who have no known evidence of disease, a clear mammogram, hormone therapy can do a couple of things. We see that hormone therapy can increase breast density. So it is important to get your regular screening mammograms if you are on hormone therapy. So you may be a category B and then move to a category C. The second thing is we see that for the first 5 years of someone being on menopausal hormone therapy, their risk seems similar to the average population. But for individuals using a progesterone or a progestogen after the 5 years, they have a slightly higher increased risk, an extra 1 in 1,000 compared to their own baseline average. And if they have other risk factors such as sedentary behavior, drinking alcohol, plus all of the uncontrollable risk factors, we have to consider that on top of it. Regardless of if somebody chooses to take hormone therapy or not take hormone therapy, knowing their breast health, having conversations about risk factors, getting regular screening should all be part of the conversation. And most people, and most patients are actually left in this gray zone where they're either living in fear or have no fear at all, and then they might miss their screening. It was interesting earlier, not to go off on a tangent, but when we talked about social determinants of health slightly, about maybe things are in your control, maybe things aren't in your control, I read a study that really disturbed me, and it said that even people of higher socioeconomic status are still not getting their regular screening mammograms. So we can't, as much as we would like to see. So we can't just blame social determinants of health on not screening. If you are lucky enough to get your mammogram covered, do not miss your mammogram. We are all busy, but that is a hill I will die on. Please don't miss any of your screening. Having said all of that, The conversation that I am navigating with patients is always a risk versus benefit conversation. Hormone therapy is a medication, and hormone therapy makes so much difference with patients. However, we are giving it for menopause and perimenopause. And although it can make a huge difference, there are other factors that we have to consider about the perimenopause and menopausal experience, such as nutrient deficiencies, potential thyroid issues, if a patient has previous comorbidities like PCOS or endometriosis. We have to manage those things, not just give somebody hormone therapy. And a lot of my patients who may have a history of estrogen positive breast cancer and may not be eligible for systemic hormone therapy do feel very left out of the entire menopause conversation. And it's important for me to remind them and for us to have this conversation with them that hormones, hormone health, and menopause health is about cardiovascular disease, bone health, sexual health, quality of life, sleep, mood. It is more than just hot flashes and hormone therapy. So I think as providers, we really need to talk to patients about all of the factors that can happen in menopause, not just hormone therapy. And I think you and our colleagues do an excellent job of this, but I thought I'd say it anyway.
Yeah, totally. There's hormone therapy in the conversation everywhere nowadays, and that's going to simmer down at some point. But to use your analogy of the pendulum swinging from earlier, it is swinging in one direction after it was in the complete opposite direction for so long. And now, because we also have sensationalized claims about what it can do and what it can't do, but really more about what it can do, I think this is where patients are feeling confused and sometimes, to your point, like really left out of the conversation when they're suffering and maybe they've tried all the other things to support their cardiovascular health. Their nutrition is dialed in, but they're having vaginal dryness or GSM, which is genitourinary syndrome of menopause, or maybe their hot flashes aren't managed by anything else, right? So there's nuance and individuality in that conversation. And I want to go back to something you said about the social determinants of health and socioeconomic status, because I was going through the Canadian Cancer Society's website, and one of the things that they had listed as a risk factor was that breast cancer risk is slightly higher for women with higher incomes, which I found so fascinating because typically when we think about higher socioeconomic status, we see better health outcomes. Now, the thing that they listed on there was this might be related to other risk factors such as having children later in life or having fewer children or no children. Some of it, to your point, has to do with screening. Do you have anything to add to that? Any insights that you can offer? Because my thoughts also go a little bit toward longevity in those high income people, right? Like, and with age, we have a higher incidence anyway. But yeah, I would love to hear your thoughts on that.
That's such a good observation, Anne. And you're amazing at making these like observations that not a lot of people might consider. I think it goes back to cancers, all cancers, breast cancer included, being so multifactorial. So one of the considerations might also be about if an individual may choose to have children later. So if they have a higher socioeconomic status because maybe they have went to school longer, so they will hold off on having children, that can increase the risk factor, or they may have no children at all. Again, this could be socioeconomic status. It could just be maybe my own bias about what I'm observing with patients as well. We also see that in certain populations, they may have a higher incidence of cancer, but their survival is also higher. So if somebody is actually getting more screening, more cancers will be detected as well. We may see less incidence in certain populations, but when we catch their cancers, there might be a lower rate of survival, or those cancers may be more aggressive. So it doesn't necessarily mean that it's a good thing or a bad thing. About cancer incidence, we also have to ask these, not just the confounding factors, but also ask these other questions. I'm not sure that exactly answered your question, but those are just some thoughts that came up when you were mentioning it to me.
Yeah, and I love hearing your thoughts.
And
Also, I was just wondering if there is as much data collection from countries who are lower on the socioeconomic scale, right? Because I'm looking at the wording and it says breast cancer risk is slightly higher for women with higher incomes, which doesn't actually tell us about country, although this is Canadian Cancer Society, so I assume it's Canadian. But it's interesting to think about all of these things that can contribute over time, and it's not a standalone one risk factor that we can put above the other. And that's what happens in chronic illness and complex illnesses like cancer, right? Like it's not just one thing, it's a multitude of things, which is exactly what we have talked about so far. Now I want to move toward screening, because as you know, there's a lot of misinformation about mammograms. So screening, as we know, or for anyone who doesn't know, screening tests are performed in order to catch health problems that are more prevalent in certain demographics. Think about blood sugar monitoring and immune status in pregnancy, blood pressure and cholesterol monitoring as we get older, cervical cancer screening, colon cancer screening, and breast cancer screening. Who should, this is a broad question, be getting a mammogram and when?
so if you are born with ovaries, so born as a female, you should be starting to get mammograms at the age of 40 if you are of average risk. If you are a higher risk individual, and this is determined by a number of things, mostly including family history. So we're looking at a first degree relative. So that's a mom, a sister, or a child. You want to get screening sooner. If you have a history of radiation to the chest, so for childhood cancer survivors, they might also have to be screened sooner. For the most part, though, the average individual should start their screening at the age of 40. And if their screening is, if there's nothing concerning in their screening and their breasts are not dense, every 2 years thereafter, up until the age of 75. Some of these individuals may need supplemental screening, and that makes sense too. When we're looking at screening as well, the idea is that we know we're not going to be perfect. So no screening exam is perfect. And I think that's also important to remember, because sometimes when I'm talking about screening with people, they will say, but my friend did all of their screening and they still got cancer. Even though we are screening for cancer, the point of screening for cancer is to detect cancer. So if you are going for your screening and cancer is detected, it somewhat has done its job. It's not like other preventative measures where you would not get cancer because we're trying to reduce risk. So I think that's the other thing that is brought up to me, that I went for screening and still got cancer. We also see that there's outliers to everything. I call it, I saw on another podcast, like the barnyard analogy for screening. There's sometimes slow growing cancers that regardless we would catch. There's also, and those would be like our turtles in the farm. There's also the birds, and birds are like those very high flying. They're jumping over our screening fence, and no amount of screening would probably catch them. I'm going to consider those very unfortunate individuals. Bad luck. My heart definitely goes out to those individuals, but screening's probably not going to make a difference in terms of survival. We want to catch the rabbits, which are going to be those cancers that are moving at a regular pace, and we want to catch them before they get to a place where it's going to impact survival. And if we can get screening done in an appropriate time, we may also reduce the amount of treatment that patient needs.
I really love this analogy, and really love that you brought all of that up because this is something that gets lost when we're thinking and talking about anything related to health, really, not just cancer. Right? We can take testing, we can take drug impacts, how some people will get benefit from a particular drug, some people will not. Some people will have side effects, some people will not. When we think about screening like mammograms, we're trying to catch as much as possible and the kinds of cancers we are able to catch in a way, right? Now, for those people who are concerned about radiation associated with mammogram, what message do you have?
So I think it's important as healthcare providers that we're honest with patients. Patients are smart, right? So I think where maybe we've gotten ourselves into problems in the past is, I don't know if gaslighting is the appropriate word, but we'll say being very dismissive of patients' concerns because maybe in our mind, there's not a magnitude of risk. So instead of just talking to patients appropriately, like adult to adult, we will be like, don't worry about it. It's nothing. So mammograms do use radiation. There is an X-ray involved, which again does involve radiation. However, when we're talking about the magnitude of effect, the magnitude of effect is very, very small. We all have a safe limit of radiation that we can receive every year. We get radiation from just moving through the world. You get radiation from flying in a plane, regardless of if you go through the X-ray screening or get pat down. And I think that's important to, again, compare it to other aspects of our life that we may be getting radiation. If you use a photocopier, are people even using photocopiers anymore? But I know that's a thing. Either way, the point being is that the amount of radiation that we do get from mammograms is significantly small, and the amount of lives saved per potential cancers induced with mammograms, the benefits far outweigh the risks. I would say that you and I, and probably everybody listening, gets more radiation walking through the day or like that cumulative effect over the year than we do from a mammogram every year or every other year.
Mm-hmm. We have to hold every decision, and for patients, it is like every decision that they're making, right? It can come with fear, it can come with anxiety and apprehension. They've likely thought about it and mulled over it in their heads and tried to look it up and gotten conflicting information. So the context is really important. I think just having that conversation, that very human conversation, is what can potentially be life-saving, because that's really why we want to do mammograms in the first place, is to catch it and hopefully be able to treat you in time. For the most part, there will always be outliers, to your point.
I always welcome conversations like that in my practice. When patients come to me and say, well, I have heard this about mammograms, or I've heard I shouldn't get a mammogram, or I've heard that thermography is a better choice, I welcome those conversations because it shows that patients care about their health, that they're doing their own research, and they feel comfortable enough in the space that they're in with me to advocate for themselves, and they want to learn more. And to me, that's an amazing patient. And these are conversations that this is my job. This is what I love to do. So if you're listening and you are a patient and you do have concerns about screening, any medication or any medical procedure, please bring them up to your provider. It is their job to listen to you, and it is their job to have that conversation with you so you can understand why they're giving you that intervention and any potential risk associated with it.
Yeah, it's all part of the shared decision-making process, right? Like you feeling good about a decision or good about whatever you're doing in your health. Part of that is essentially asking questions, weighing the risks and the benefits. And the only way you do that is through discussion, really. and then coming to whatever solution or direction that you're coming up with together. I also really love that part of my job, the discussion part, the patients bringing in questions. And I actually want to ask you a question about soy because that's one of the questions that comes up really often. But before I do, I want to wrap up the imaging piece. Apart from mammograms, you had mentioned like thermography, ultrasound. When are those appropriate and relevant?
Ultrasound is appropriate if individuals have dense breasts and we might not be able to see things on mammograms. This would be recommended by your medical doctor, depending on the jurisdiction you're from. It would also be recommended by the radiologist who is reading your mammogram as well. And then in certain clinical decision making, if a person is getting a clinical breast exam and something comes up that the doctor feels that an ultrasound would be appropriate, you would get an ultrasound. And in some people's case, even an MRI would be appropriate. Thermography is appropriate, frankly, never. There are no clinical benefits that have been shown to come from thermography. And the reason why is when we're looking at a screening test, kind of, does it pass the risk-benefit conversation? Part of the challenge with thermography is that a lot of things can be missed and a lot of things that aren't concerning can be picked up. So we're not really learning anything new by getting thermography done. The other challenge with thermography is that if something is shown to be risky, the next intervention is essentially a mammogram. So part of the challenge with going for thermography instead of booking your mammogram is you may be actually delaying something that is a concern. If patients want to do both, it is their choice. Just because something is not evidence-based and I wouldn't recommend it doesn't mean that it's necessarily harmful, but doing thermography instead of a mammogram is harmful.
Okay, that's that, period.
Can you tell I'm very passionate about breast screening?
Okay, and then to my other question, what message do you have or what evidence can you give us for people who might be concerned about soy consumption and breast cancer?
Similar to what I said about mammograms, when people say soy is estrogenic or I've heard soy is bad, I do like to not just be dismissive and actually say, I can tell that you did probably hear that from somewhere. And also even be vulnerable with the way that my practice has changed and say that when I started working in the cancer space, oh my gosh, close to 20 years ago, I used to tell people, and the oncologists used to tell people, stay away from soy. And the reason why is the initial studies from soy were in rats and cell studies. And these were in the 90s. So just like, well, even though the 90s has made a comeback, maybe in some ways, in medicine, 90s has not made a comeback. So I think it's also important to share with patients where their information is coming from, what part of it is true, and what part of it has evolved. What we're seeing in these cell studies aren't really indicative of what's going to happen in humans because you can pretty much kill or grow anything in cell studies. It's just those initial preclinical things. And I don't know about your practice. I think we practice similar. We don't really place much value in cell studies, but we have to start somewhere. With rats are not humans, so we process things differently. And soy is definitely one of them. So there's different estrogen receptors, estrogen receptor alpha, estrogen receptor beta. We have both, rats do not. So in these initial cell studies, when we're actually giving rats cancer, first of all, and then giving them soy, in frankly such high doses, I don't think any human, no matter how much you love edamame or tofu, could ever have. We did see an increase in cancer in these rats. However, when we're looking at human studies, moving forward. And when I say human studies, I'm not talking one, I'm not talking two. We are talking like over and over again, different populations, um, people who have estrogen positive breast cancer, people who have a history of estrogen positive breast cancer, premenopausal patients, postmenopausal patients, every iteration of hormones that you could possibly think of in humans. Soy has been shown to be beneficial or do nothing at all, but most of the time beneficial. So we actually see a decreased risk of breast cancer in individuals who consume soy. Soy is safe to have even after you've been diagnosed with breast cancer. Soy is excellent. Things like edamame have high calcium, high fiber, high protein. Can't say that about a lot of foods. These plant-based proteins are also really great in satisfying your protein requirements, fiber requirements, lower saturated fats, which is part of this, we could say like an anti-cancer type of lifestyle. I cannot say one bad thing about soy in the year of our Lord 2026. Soy, soy is it. And it seems like it's been that way for quite some time now.
Okay, so now as we approach the end of our time together today, what are the guidelines around self-screening? Like, is there benefit to like self-breast assessment? And if so, what are we looking at and looking for?
So this is where nuance definitely comes in. There was this time where we were telling patients not, I wouldn't say, we've never told patients not to do self breast exams, but they were not really encouraged because the idea was patients were finding things, going to the family doctor, and then causing potential interventions that never amounted to be anything. However, anybody who works in the cancer space or frankly works with patients who have breasts or knows somebody with breasts have all met somebody who self-detected a cancer. And now the conversation is more about breast self-awareness. I still encourage my patients to know their breasts, do breast exams, and I would say the research is on my side about that. We also see that if you know your baseline breast health, then you're more likely to find something that is changed. So therefore, what you are finding, it's important to be checked out. Whether it's something benign or not benign, it's still important to know when we're looking for changes. So knowing your baseline, knowing what your nipples look like, knowing that some people have a little more asymmetry than others, but if your symmetry changes, that would be something to know. Looking for any indentations, any swelling, the look and feel of the lumps and bumps that you have. So there are conversations about if the lump that you feel is, smooth and attached or detached and everything's okay. I would just say know your baseline. And then if anything changes from your baseline, get it checked out. I also am a patient advocate for if anything seems off, just say something. Um, I do not agree with you could be burdening the medical system. You're not. It's your life. No one's ever regretted getting something checked out that turned out to be benign. And no one's ever regretted getting something checked out that turned out to be cancerous. So check your breasts, know your breasts. If you see something, say something.
That's sort of how the healthcare system works. You do have to advocate for the things that you're noticing. If someone listening wants to reduce their risk of breast cancer today or starting today, what are the big ticket items? Where would you direct their focus?
So we're going to look at the World Cancer Research Fund and look at the 4 biggest interventions that you can make. So the first is going to be limiting, or I would say eliminating alcohol and tobacco. The second is going to be physical activity. So we see that individuals that have more physical activity do have lower incidences of cancer. Although, as I mentioned before, plenty of people who are physically active do get cancer. I also want to mention that those individuals do have a higher rate of survival and better recovery as well. So exercise is so important. We see that individuals who consume fruits and vegetables, at least 5 servings per day, do have lower risks of cancer as well. So we want to encourage fruits and vegetables. And part of that is also due to having adequate fiber can also reduce risk of cancer. And you can get a lot of fiber from fruits and vegetables. The last one, and this is where some nuance comes in, is having a normal BMI does reduce your risk of cancer. BMI is not the end all and be all. So I translate that to my patient as having appropriate muscle mass compared to your fat mass. And generally, if we're following a healthful eating pattern and we're getting exercise and our metabolic markers such as blood sugar, blood pressure, cholesterol are all within normal ranges, then we're generally good in that. But I think it's easier for the World Cancer Research Fund to just say normal BMI.
Yeah. Without going into all the nuances of BMI and the history there, for sure. Okay. And then how about for the listener who knows that they're high risk because of their family history or the presence of a gene like BRCA2 or something like that? What's one or two pieces of advice that you would have for them or words to consider to help them manage the anxiety and take back some control?
I love this question. So I work with a lot of patients who have genetic predispositions to cancer. And the first thing is finding a team of healthcare practitioners that you feel very confident with and comfortable with and make you feel empowered about the decisions. Some individuals that are flagged as having these genetic risks will have decisions to make, such as considering removing ovaries or considering mastectomies prophylactically. And it's not necessarily a decision you need to make today. That's why it's important. There's a lot of nuance that goes into these big decisions. So have a healthcare team that you feel good about. Just because you have a predisposition also doesn't mean you will get cancer. So it's also important to know that even though there are some odds that are not in your favor, there are a lot of odds that are. I also want to make a comment about just because someone does have a BRCA1 or BRCA2 gene, it does not mean that they cannot receive menopausal hormone therapy if it is indicated. So if you do see a provider and immediately upon hearing BRCA1 or BRCA2 is in your history, without asking you any other questions, they shut down the conversation about hormone therapy, I would encourage you to dive a little deeper into the research on that because there is a lot of nuance. So I don't want individuals who do have a genetic predisposition to cancer to feel that they may not be eligible for hormone interventions in the future.
Thanks for that, because it does feel like an absolute contraindication when it's not. It's all relative to where in your journey you are, what else is happening in your body, and you coming to a solid decision and revisiting that decision many times if you need to with your health team. Now, is there anything else that we didn't talk about that you'd like to share, or some final words of wisdom to anyone listening?
If you are listening, and I think I said this before, but it bears repeating, if you are eligible for screening, please take full advantage of it. Even if you are busy, please make the time to get your screening. Also, if you do have a diagnosis of cancer, get a diagnosis of cancer, or have a cancer scare. This is not a punishment. You did nothing to deserve this. even if you were doing all of the things that might be like part of those risk factors, no one deserves cancer. So I like to let people know that if they did get cancer, it's not their fault.
Thanks, Ashley. Before we wrap up, final two questions for you. Number one, here at Face to Face, we're really big into learning and growing, especially as we get better as humans and individuals, hopefully with time, and also as science and our understanding changes over time. You already touched on one, which was the soy, but is there another concept or strategy within your professional expertise that has changed or that you've changed your mind on?
Oh, I love this question. I'm going to pick two things. One, I want to call out my thoughts about hormone therapy. When I started practicing, I definitely was like shut down to all forms of hormone therapy, including local vaginal hormones in patients with a history of breast cancer. So I want to call myself out to say that that's no longer the case. I'm up to date on the research and very comfortable with that. The other thing I want to call out too is the conversation about organic versus inorganic. People in general are not getting enough fruits and vegetables. So 90% of North Americans are not hitting the adequate amounts of fruits and vegetables, regardless of socioeconomic status. And that includes cancer survivors. All of the research about fruits and vegetables being great are with non-organic fruits and vegetables. So I don't want people to feel like if you are not eating organic or can't eat organic or organic isn't available to you, that fruits and vegetables are bad. And I don't want people to feel like if they are eating inorganic, that they have a higher risk of cancer. We won't spend too much time on it today, but the bulk of the research with cancer and pesticides actually have to do with the farmers and lymphoma, not the people who are consuming the products. There is very rigorous testing and rules. Your non-organic fruits and vegetables are very safe for you to have. And that's something I've changed my mind on.
I'm there with you. And question number two, where can people find you, learn more from you, and connect with you?
So the clinic that I practice is Clarity Health in Burlington, Ontario. If you are an Ontario resident, I see patients both in person and virtually, so you can connect with me there. I spend a lot of time on Instagram, and my handle is at Ashley Chauvin _ND. And those are probably the two best places to connect with me. I also have a website. If you Google my name, drashleychauvin.com, that will also come up. So I am findable.
And I will link Ashley's notes in the show notes. And if you want to learn about more about what we talked about today, I'll throw in some other resources like Dense Breasts Canada, as well as the Cancer Society's information on breast cancer. Ashley, thank you so much for being here. Thank you for sharing your wisdom with us and really helping contextualize all of those risk factors and to further our understanding that it's not one thing that we got to do or one thing that caused it or that we caused it in general. And I really hope that if there's one takeaway from this episode, that's the one for people, and to do your screening. I'd love for you to share this episode because everyone deserves to learn more about their bodies. Make sure to subscribe and follow wherever you get your podcasts or at facetoface.ca.